Hi everyone, and in this video we'll be discussing the anti-malaria drug. So another protozoa. There are two important malaria parasite, that is Plasmodium falciparum, and one more is Plasmodium vivax. The problem with vivax is relapse. The problem with falciparum is it is becoming resistant, and we need to use combination therapy in managing this falciparum malaria. In falciparum also we get complicated malaria like cerebral malaria, and we need to manage it. And people who travel to endemic area of malaria, they need prophylaxis. So, and let us understand in this video what are the drugs used in malaria and what are the prophylactic therapy and how do we manage complicated or cerebral malaria. Let us start our journey, anti-malaria drugs. Now, so when we think of malaria, we have two important protozoa, Plasmodium falciparum and Plasmodium malaria. Then we have Plasmodium vivax and Plasmodium ovale. Now these two malaria parasites are known to produce relapse. So there is a chance of relapse. Even though you have treated it, again the infection may reappear, and that is called relapse. To understand this topic, let me begin with a case. 25-year-old lady residing in Chennai presents with a 1-week history of intermittent fever, chills, acute abdominal pain, and excessive sweating. Physical examination reveals an acutely ill patient with a tender abdomen, with a soft, tender, slightly enlarged spleen. Urine analysis shows traces of albumin and no bacteremia, so it's not a case of UTI. A peripheral blood smear showed ring forms of Plasmodium falciparum. So the diagnosis is given, it's a Plasmodium falciparum. Remember, in India, when you see the patient with fever and chills, always rule out typhoid, UTI, then bacterial infection, particularly the bacteremia, and then malaria. So it's a case of uncomplicated falciparum malaria. How do you manage this? We'll find out the answer in the end. Now we'll start with the drugs. To understand the drugs, first of all, we need to understand the malaria life cycle. I think you studied in microbiology, so it's like an integration with that. Let us understand the malaria life cycle. With that, we'll also understand what drugs act on what phase of the cycle. Okay, we'll start the journey. Now, this is the malarial life cycle. So let me start from here. The mosquito bites. So when the mosquito bites, then what happens? The sporocytes enter the human circulation. Now when the sporocyte enters, they enter the liver. Now when they enter the liver, these sporocytes start multiplying. So you can see here, they start multiplying. Now this stage is called the pre-erythrocytic stage. So before infecting the RBCs, there is a stage in the liver that is called pre-erythrocytic stage. Now after this, they become tissue scissions, and some of the sporocytes, they are sleeping in the liver as hypnocytes. So this is seen only with two important malaria parasite, that is vivax and ovale. And this hypnocytic stage is also called as exoerythrocytic stage. Now please remember, if these hypnocytes are not killed, after some day when they get up, they can again come back to the tissue scission stage and again cause malaria. We call it as relapse. Patient may have relapse again. Now these tissue scissions are released into the circulation. They are called merocytes. Merocytes enter the RBC. What do they do when they enter the RBC? They increase in number, and when they increase in number, the RBC will rupture. When the RBC ruptures, the parasites are released in the circulation, and then the patient will have fever and chills. That's the reason why the patient complains of fever and chills. Again, these merocytes again infect the new RBCs. So every time they do this rupturing, patient will have the fever and chills. Now, the parasites, they also form gametes, the male and female gamete, in the circulation. Now, when another mosquito bites this infected person, the mosquito will take up the male and female gamete, and the fertilization occurs in the mosquito, not in the humans. and that is called a sexual cycle. So sexual cycle occurs in the this thing mosquito, and when the sexual cycle happens, they release porocytes. They are stored in the saliva of the mosquito. So again, mosquito bites a non-infected person, he will again get malaria. So this is in brief the malaria life cycle. I think you have studied that in microbiology. So this is just a revision for it. Now there are certain drugs which can be used to prevent malaria. Now suppose the patient is in an endemic area and he got exposed to mosquito bite, or he is entering the endemic area, we don't want a person to get. So there are drugs which can act in the pre-erythrocytic stage. There are certain drugs which can act on the pre-erythrocytic stage, and these drugs which act on the pre-erythrocytic stage or liver stage, they are used for causal prophylaxis. These drugs are used for causal prophylaxis. Now what are the drug names? Now the drug name is primaquine. The name of the drug is primaquine, and one more drug is called proguanil, and one more is called atavocone. So these drugs are usually given as causal prophylaxis when the patient is traveling to the endemic areas. Now there are other group of drugs which can suppress the clinical manifestation of malaria. So we use these drugs as suppressive prophylaxis. So suppressive prophylaxis. Now what do? They interfere with the erythrocytic stage. They don't allow the RBCs to rupture, and they will not allow the fever to occur. Now these are used for prophylaxis. And what are the drugs here? The name of the drug is mefloquine. The name is mefloquine. And one more drug is called doxycycline. And one more is chloroquine. Now in our country, we don't use chloroquine as prophylactic because already we are facing chloroquine resistant cases, so we don't want to use it. Two most common drugs what we use is mefloquine and doxycycline. So even the person has been exposed to malaria, he will not get the clinical manifestation, that is fever and chills. So this is the reason why it is called, you are suppressing the clinical manifestation, that is fever and chills. They are mefloquine and doxycycline. Now once I understood the causal prophylaxis and suppressive prophylaxis, now importantly I need to understand, what if I have to prevent the relapse? The reason for relapse is hypnocytes. If you kill the hypnocyte, patient will not get again malaria. The drug which kill the hypnocytic stage, there are only two drugs. The name is primaquine, and one more drug is called tafenoquine. So primaquine and tafenoquine are the only drug which are going to kill the hypnocyte. What is the stage called? Exoerythrocytic stage. Now what happens if they kill the hypnocytes? These drugs can decrease the relapse. These drugs can decrease the relapse, and the cure is called radical cure. Now why it is called radical cure? Now when you treat a malaria patient, if you are treating the malaria, you are killing the malaria parasite, but hypnocytes are not killed. That means you are not curing it completely. There is something remaining. Radical means from the root. You are killing the parasite, even the hypnocytes. So it is complete removal. That is the reason why it is called radical cure. So we understood three things: causal prophylaxis, suppressive prophylaxis, and radical cure. There are only two drugs, primaquine and tafenoquine. Now, what about the fever and chills? Now, fever and chills, and that occurs in erythrocytic stage. So that is seen in erythrocytic stage. Now, the drugs which act on erythrocytic stage, they are called erythrocyte schizonticides. Now, these drugs which act on the erythrocytic stage, there are two categories in that. The one which has high efficacy. These drugs have high efficacy and they are fast acting. So high efficacy and fast acting, and one more is low efficacy and slow acting. So these drugs which act on the erythrocytes, they are also called as the drugs used for clinical cure. Now these are the drugs which are going to bring down the fever, bring down the chills, and I will tell them in detail later what are these high efficacy drugs and what are these low efficacy drugs. Now, is there any drug which can kill the gametes? Now, what is the problem with gamete? If a person is infected with malaria and some mosquito bites, it will take the gamete and it will again spread the malaria to somebody else. So I need to kill the gametes. There are vivax and falciparum. What is the drug which can kill the gametes of vivax and falciparum? The drug is primaquine. The best drug is primaquine. So whenever I write primaquine, his brother tafenoquine also comes here. Now these are the one which will kill the gametes of all the species. So please write down this line. It kills all species gametes. So all species gametes. This is one of the question which appeared in your recent exam. Is there any other drug which can kill the vivax and falciparum? Yes, we have group of drugs called artemisinin. But these are not so much effective. They have low efficacy in killing the gametes. They have low efficacy. Is there anything which kills the vivax gamete? Yes, we have the chloroquine and quinine. They are known to kill it. But I want you all to remember the primaquine and tafenoquine mainly. So what happens if I kill the gametes? If the drugs are gameticidal, what do they prevent? They decrease the clinical transmission. So they decrease the clinical transmission of malaria. Yes. So this is the point I understood from here. Now if you see into this image, you can see here, I have told you what are the important things here. I'll just mark them. So causal prophylaxis, the drugs act on the liver stage and they prevent a malaria manifestation. Suppressive prophylaxis, mefloquine, doxycycline, they don't allow the fever chills to manifest. So usually these drugs are used for prophylaxis. Suppose somebody is traveling to endemic area. Suppose there is vivax and oval malaria, then you have to kill the epinocyte. For that, the best effective drug is primaquine and tafenoquine. Now for clinical cure, to reduce the clinical symptoms, what we use are the drugs which are high efficacious and low efficacious combination are used. The drugs which are used to prevent the clinical transmission, they are gameticidal agents. So these are the concept you need to understand. Okay. Now if you observe everywhere primaquine is there. But one place primaquine is not there is it will not work on erythrocytic stage. Otherwise, primaquine will be the best drug and one drug would have done everything, wonder. But it doesn't have anything to do with erythrocytic stage. It will not have the property to decrease the fever. And that's why it has to be given with other drugs. So let us start with the first concept, the drugs which are used in clinical cure. The drugs which are used in clinical cure, or they are the one which act on erythrocytic stage of malaria. And what do they kill? They kill the seasons. So they are erythrocytic seasonticidal agents. Now once I know this, let me tell you this. Now the clinical cure, I told you there are two variety of drugs. The high efficacy. So the efficacy is high with them. And also they will work faster, fast onset. They are called fast acting. And these drugs are low efficacy and slow acting. So first of all, let me tell you these drugs because you already know these drugs. and we have studied these drugs in the antibacterial drugs. So we have studied these drugs. If I write here, and then you know what are these drugs, sir? Have you studied that? Yes. Now the drugs are, the name is tetracyclines. So when I discussed tetracycline, I told you we use them in malaria, mainly tetracycline. The drug used is doxycycline. I have written that already. Then one more which binds to 30S is tetracycline. One more which binds to 50S. The drug used is clindamycin. And the rest all drugs are the drugs which affect the folic acid synthesis or they inhibit dihydrofolate reductase. What are those? The drug are dapsone. So dapsone is used in leprosy also, but it can be used in malaria also. Mainly it inhibits what enzyme? Folic acid synthesis. The next important drug is a drug by the name proguanil, and one more is pyrimethamine. These drugs inhibit dihydrofolate reductase. One more in that path, they are sulfonamides. So we also use sulfonamides in the management of malaria. And the sulfonamide what is commonly used is sulfadoxine. Usually sulfadoxine is combined with another drug, pyrimethamine. Sulfadoxine plus pyrimethamine, and we have discussed these drugs in detail already. Sir, what should we discuss is the high efficacy and fast acting. In high efficacy and fast acting, let me tell you two important drugs. What are the two important drugs, sir? Now, usually the mechanism of actions are not so much important in anti-malaria topic, but just I will give you. There is something called heme in the RBC. Heme is converted into hemazyme. Now this step is inhibited by certain drugs. Now what happens if I inhibit this? The heme increases and that is toxic to the parasite. Toxic to parasite, and it will kill. Now what are the drugs which have this property? Remember any drug ending with quin, for example, chloroquine. Okay, chloroquine. So chloroquine has the property. Now if you remember, if you remove chloro, you get quinine. Then the drug mefloquine. And one more drug is called amodiaquine. And don't confuse primaquine. They mainly act by causing free radical damage. So that is one aspect. Another group of drugs which are high efficacious and we use left and right, they cause free radical injury to the parasite. They cause free radical injury to parasites. And these are nothing but they are called as artemisinin derivatives. So we'll discuss about them later. Very important drugs, artemisinin derivatives. Now they are the best drugs. Now once I know this, what about the other group of drugs which have the different mechanisms? Let me tell you this. Yes. So in that we have a drug which inhibits the electron transport in the parasite. And what happens if you inhibit the electron transport? Obviously there is decrease in ATP, and when there is decrease in energy, the parasite will not survive, and the name of that is called atavocone. Sir, we have heard of atavocone already. Yes, atavocone is used in two important places. One is to manage babesiosis. So it is used in the management of babesiosis. Now we use atavocone with azithromycin in the management of babesiosis. This combination is the drug of choice for babesiosis. We have discussed that in anti-protozoal drug. Apart from that, it is also used in pneumocystitis, Zero-C. So again, it is used in toxoplasmosis. Okay, that is the other uses of atavocone, but mainly you have to remember the use in babesiosis. Now, another group of drugs which are known to inhibit the proton pump in the malaria parasite, and the name of these drugs are lumefantrine. Lumefantrine. Lumefantrine, pharmacokinetically, they will ask you because the fatty food increase its absorption. Fatty food increase the absorption of lumefantrine, and I have discussed that point in general pharma also. Then we have a drug called halofantrine. So they end with fantrine, halofantrine. Now remember H, heart. So it is having adverse effect. It is cardiotoxic. The name is halofantrine. So these are high efficacy, fast acting drug. Let me repeat them. These are the things: the chloroquine, quinine, mefloquine, amiodarone, then artemisinin derivatives, atavocone, lumefantrine, and halofantrine. These are the faster acting ones. Now, please understand mefloquine, whenever they ask you in the exam, what is the adverse effect? Remember mefloquine for mental. So it can cause neuropsychiatric adverse effect. Neuropsychiatric symptoms. That means patient may have the seizures, hallucination, illusion, all these things. So why they will ask you in this question? Because if the patient is having cerebral malaria, what drug you should not use? Mefloquine. So mefloquine is contraindicated in a patient with cerebral malaria, because in cerebral malaria, patient is already in confused state, and we don't want to confuse him further by giving these drugs. So that is the point. Sir, why should we have this high efficacy, low efficacy drug? Usually we give them in combination to avoid resistance problem in the parasite. That's the reason. Okay, so once we understand this, how the drugs work, now let us understand what are the most important drugs in this. The most important drug is the drug by the name chloroquine. The name is chloroquine. Very, very important. Pharmacokinetically, when we discuss this drug, it has high volume of distribution. So approximately 1300 liters. The meaning of this is the drug will not stay in the blood vessel. Whenever we give it, will go out. So it can get stored in the tissues, and the problem is toxicity. It can cause retinal toxicity and other problems. I will discuss that. Now, pharmacokinetically, the drug has high VD, and because of high VD, we have to give a loading dose. The drug should be given as loading dose followed by maintenance dose. Followed by maintenance dose. Maintenance dose. So you correlate general pharma here. Loading dose, what we give is 600 milligram. Now, why did we give loading dose? Because it has high volume distribution, and then followed by 300 milligram is given as maintenance dose. So loading dose depends on volume of distribution. Maintenance dose depends on clearance. So we have to correlate general pharma everywhere. So once I know this, what is the adverse effects are you are talking? The drug is going to get stored. Most importantly, it causes retinal toxicity. So the patient will have a maculopathy called bull's-eye maculopathy. Patient will have bull's-eye maculopathy. What is bull's-eye? It will be like this. So it will be like this. So the concentric arrangement, what we play the dart with, so it looks like that. That is bull's-eye maculopathy. The macula looks like that. The second problem is it is going to cause corneal microdeposits. Corneal microdeposits. So recently this was asked in your exams. Please note that. And also the drug is known to cause pigmentation. Where? Nail and mucous membrane pigmentation. Nail and mucous membrane pigmentation. Again, this is again the question for you. So whenever you think of chloroquine, you have to think of the eye. So the eye is the bullseye maculopathy and the cornea, the front of the eye, back of the front corneal deposit, back bullseye maculopathy. Another E you should think of is ECG. So whenever you think of chloroquine, think the EC changes, it causes QT prolongation. What is the one more derivative of chloroquine which can cause QT prolongation? Yes, you are right. It is hydroxychloroquine, which is used in rheumatoid arthritis that can also cause QT prolongation. Now the question is it safe in pregnancy? Yes. It is one of the safest anti-malarial drug that can be used in pregnancy. Okay, sir. So once we know the adverse effect of chloroquine, let us understand the uses of chloroquine. So uses of chloroquine. So where do you use it? Number one, we use it in rheumatoid arthritis, RA. Then it is used in extra-intestinal amoebiasis. Now this is not a drug of choice, but it is useful there. And one more is it is used in DLE. Sir, what is DLE? DLE stands for discoid lupus erythematosus. Discoid lupus erythematosus, there we use it. It is used in the lepra reaction. Lepra reaction are two types, sir. Which type we do use it? We use it in type 2 lepra reaction, also called as erythema nodosum leprosum. Now it is also useful in infectious mononucleosis. And it is also useful in photogenic reactions. Then what we are discussing now, malaria, it is useful. And one more important thing is giardiasis. So we have a age-old mnemonic for this chloroquine, which we are using from our UG days. The mnemonic is red lip. You can consider as Menaka Gandhi, Mahatma Gandhi, whatever. Remember that. So the mnemonic is red lip MG. So this is the use of the drug chloroquine. So chloroquine is most important, and you should know how the drug works. Now many times they may ask in detail what is the mechanism of action of chloroquine. Let me write here. Mechanism of action of chloroquine. Let me explain here. Right. So the chloroquine enters inside the cell. Okay, let me write again. The chloroquine enters inside the cell, and pH inside is acidic, and it will become ionized because of this acidic pH. So what does it do? The chloroquine gets trapped inside, and number one, it inhibits the conversion of heme to hemosyne. So this chloroquine is going to inhibit the conversion of heme to hemosyne. This is the major action. Now in the parasite, there is a food vacuole. So there is a food vacuole. This is called food vacuole. Let me write that. This is called the food vacuole inside the parasite. So it will go inside and it inhibits the formation of peptide bond. So it inhibits the formation of peptide bond. Now what happens if peptide bonds are not there? It decreases the amino acid levels. So this is another mechanism of action. So let me complete this. So this is what the chloroquine does inside the parasite. So main mechanism is this one, guys. Please remember, it inhibits the conversion of heme to hemosyne. That is the major mechanism of action. And in the food molecule, it inhibits the peptide bond. Right? So this is the important aspect of chloroquine mechanism of action. Now whenever we think of chloroquine, Again, a similar kind of drug we need to understand. So one more drug related to chloroquine is called quinine. Quinine is given intravenous. Now, where do you use intravenous quinine? In a complicated malaria, or what we call it as cerebral malaria, we use it. Complicated malaria. Now, when we are giving this IV, there are two complications we have to watch out for. What are those two complications when we push it IV? The number one, the glucose may fall down. Patient may have hypoglycemia. And most of you remember, quinine looks like quinidine. Quinidine is a class 1A antiarrhythmic. So if you give that high dose, patients may end up with arrhythmia. So these are two important complications when you give quinine IV, and that's the reason nowadays complicated malaria or cerebral malaria, the drug of choice are artesunate, because of the safety of quinine is not so great. Quinine is also given oral. It is added with clindamycin. It is added with clindamycin in the management of malaria in pregnancy. Malaria in first trimester of pregnancy. So the question here is quinine safe in pregnancy? Yes, quinine is also safe in pregnancy. And where to use it? First trimester of pregnancy, malaria we use it. Which malaria? If they ask you, it is Plasmodium falciparum. Okay, there it is used. Vivax, we can use chloroquine because chloroquine is safe. You can use it. Okay, so we finished the major drug, chloroquine and quinine. The next important drug, I consider it as Optimus Prime. The drug is called primaquine. I think most of you have heard of Optimus Prime from the movie Transformer. That is the prime drug. Now, why I consider the drug as prime drug? Because it acts on the exoerythrocytic stage, it acts on pre-erythrocytic stage, as well as gametocytic stage. So it can act on pre-erythrocytic stage. So the one stage which will not work on is no action on erythrocytic stage. So that's the reason you cannot use it alone and the fever will not come down. The major use of primaquine is number one, it is the drug used to produce a radical cure. So this is a repeatedly asked question. Second, it decreases relapse. The drug is known to decrease the relapse, and it is contraindicated in a patient with G6PD deficient. It is contraindicated in G6PD deficient patients because in them it can cause hemolysis. It can cause hemolysis. Now, what happens in G6PD deficiency? We have discussed in pharmacogenetics also. I will just brief here. If the patient is G6PD deficient, the NADPH is not produced. If it is not produced, the free radicals are not neutralized and their free radicals will destroy the RBCs. So if the G6PD is working, the free radical cannot damage the RBCs. So primaquine is the one drug which can generate free radicals and damage the RBCs. Usually if I give to normal patient without any problem, they don't get hemolysis because the NADPH will protect. But in this patient, there is no NADPH and the hemolysis occurs. Second, it is contraindicated in pregnancy. You may ask a question, sir, why in pregnancy it is contraindicated? Remember, the fetus inside is relatively G6PD deficient. We don't want to take a risk in the fetus and we don't want hemolysis in the fetus. That's the reason. Now, the problem with this drug is if you want to give it for radical cure, you have to give it for 14 days. So the drug has to be given for 14 days. So we came with an alternative drug. Everything is same. That's why I call it as brother of this. The name is called tafenoquine. Tafenoquine has a very, very long half-life. Can you guess that? 14 to 19 days. So one drug will work for 14 to 19 days. So should I use this drug for radical cure for more than 1 day? No. So radical cure, you compare the primaquine. Radical cure, I can give the single dose. So that is the advantage with tafenoquine. So please analyze the options correctly. Now everything is same. It is also contraindicated GCSPD. It will also have the same. Everything is same. What is the only difference? The half-life. And another difference is radical cure. We use it as single dose. That's it. Now once we know this, we have one of the beautiful drugs of the century. Because chloroquine became resistant to falciparum, we had to discover certain drugs, and they are called as artemisinin derivatives. So these are very, very important. Artemisinin derivatives. They are derived from artemisinin. Sir, what are the drug name for that? I think you know some drugs already. The names are artesunate. The name is artesunate. Then we have RT-mether. Then RT-ether. Then arterolane. So we have arterolane. And if you know artemisinin, we have something called dihydroartemisinin. Dihydroartemisinin. Now, what are this specialty of these drugs? Now, these have high efficacy. One of the high efficacy drugs in managing malaria is artemisinin drugs. And they will produce clinical cure. That means they will work on erythrocytic stage. And they have fast acting. The onset of action is fast. So, what is the advantage? We can give them in managing which malaria? The complicated malaria like cerebral malaria. So they have fast onset of action. Another important thing is they are not used alone. They are not used alone and never use them for prophylaxis. Not used for prophylaxis. Not used for prophylaxis. Why, sir? Why? Now please remember, it is one of the best drug we have now. If I use it for prophylaxis for every people, or if I using alone, what happens? Resistance problem. So the drug can acquire resistance. So the reason why we don't use it alone or not use prophylaxis is to decrease the resistant issue. One more reason why it is not used for prophylaxis is very short acting. So patient will not take it repeatedly. That's the point. And the advantage is it has least resistance problem. Across the globe, it has least resistance problem. So this is the advantage why these are the beautiful drugs what we have for malaria, right? What is the problem here? Okay, so coming to the case what we started here, this is the case of malaria and patient is having fever, chills, abdominal pain, then slightly enlarged spleen and falciparum malaria. So how do we manage a falciparum malaria? We'll also understand how do we manage a vivax malaria. We'll also understand what if there is mixed infection, both falciparum as well as vivax. What if she is pregnant and she has malaria? How do we manage this? What if the malaria become complicated? And what if you want to travel to endemic area? What are the prophylaxis we can give? So let us start our journey. Okay, let's start. It is the treatment of malaria. Treatment of malaria. Let us start our journey here. Now first we'll take up the management of Plasmodium vivax and Plasmodium ovale. So what is the problem here? The problem is they have relapse. So still now chloroquine is effective. So we give chloroquine 600 milligram and that is the loading dose. So then after 8 hours we give 300 milligram and that is the maintenance dose. This is done in day 1. Now what we do in day 2? Day 2 we give the maintenance dose again 300 milligram and day 3 we again give 300 milligram. So the chloroquine will take care of the clinical aspect, that is it will reduce the fever. It mainly acts on erythrocytic stage. But once the parasite is killed, are we removing the parasite completely? No. Chloroquine cannot kill the hypnocytes. So it cannot affect the exoerythrocytic stage. So the only drug available to do that job is primaquine. So we have to add primaquine on the second day. So primaquine is given as 15 milligram tablet and it is given for how many days? 14 days. Sir, why are we giving it for 14 days? Because we have to wait for the hypnocyte to multiply and then kill it. So we have to wait and then kill it. Or if you want the dosage in milligram per kg, is 0.25 milligram per kg is a dose of primaquine for radical cure. Yes, fine, sir. Now, what we started our journey of this video is with falciparum. How do you manage? Plasmodium falciparum malaria or Plasmodium malariae. This one. Now, in our country, falciparum has become resistant already to chloroquine. There is no need to give. Only if it is sensitive to chloroquine, you give it, but most of the places it has become resistant. So here what we are going to do is we are using a combination therapy and that is called ACT. Sir, what do you mean by ACT therapy? It is artemisinin combination therapy. Artemisinin combination therapy. So this is what we use. I told you already, artemisinins are not used alone. They should be given in combination. Now, how do we manage this case? Let me tell you. It depends on which part of country you are treating. If the patient you are treating is of northeast, so you are in northeast part of country and you are treating the patient of malaria, then the regimen that is followed is artemether plus lumefantrine. So me for northeastern state, me. So usually in the exam they will give Assam, a northeastern state, and you have to pick the right answer, artemether plus lumefantrine. Now along with that, we add a single dose of primaquine. We give a single dose of primaquine. Now, why are we giving a single dose when they don't have relapse? The single dose of primaquine is around 45 milligram, or if you want by the kgs, it's around 0.75 milligram per kg. So here we are adding this, decreasing the clinical transmission. So it will kill the gametes and prevent the transmission. So that's the reason. Right? So that is in northeastern part. What about in rest of India? Rest of India. So rest of India, the regimen that we follow is artesunate plus a combination of sulfadoxine plus pyrimethamine. Sulfadoxine, pyrimethamine combination, and simply you can remember the SU. So matches here, SU and SU, rest of India. For that you can add a single dose of primaquine, same dose what I mentioned already. So here also we want to decrease the clinical transmission. Now you can ask a question, sir, why are we giving different regimen to different parts of the country? Now in northeastern part, already they have acquired resistance to this combination. If you give that combination also, the malaria is not going to be killed. So they are in a level up. So for them, you have to give artemether and lumefantrine combination. Clear? Okay, sir. Now what if there is mixed infection? What if the patient has mixed infection? Mixed infection means he has both falciparum and vivax together. So both are infecting him. That time, should I use chloroquine? No. If I use chloroquine, Chloroquine will not have effect on falciform, so the best therapy is to give ACT regimen. So start ACT regimen depending on the region of the country. For this, you have to add primaquine. Primaquine should be given for 14 days. Sir, why are we giving this? Because we have Vivax which can cause relapse, and to kill the hypnocyte, at least you have to give for 14 days. In ACT regimen, you have to avoid one combination. Avoid one combination. What is the combination? The combination is sulfadoxine plus pyrimethamine. This combination should be avoided. Sir, why this should be avoided? This combination is not effective on Vivax. Not effective on Vivax. That's the reason. That's the reason. So this is what we do if there is mixed infection. Okay, sir, if the lady is a pregnant woman, she is a pregnant, what to do? It again depends whether she has the Vivax or she has the falciparum. Now, Vivax, you can give chloroquine, same thing what we have discussed already. But the problem is, can we do radical cure? No, because primaquine is contraindicated in pregnancy. Sir, what happens in this case? Now, even if she gets relapse again, we give chloroquine only. But we have to do the radical cure only after the delivery of the baby, because I told you the fetus is relatively G6P deficient and there is a chance of hemolysis. So we don't want to take the risk. So what about falciparum? Falciparum, if it is first trimester of pregnancy, then we use a combination of quinine plus clindamycin. Quinine plus clindamycin. Now, you know that the most important trimester is first. Second and third trimester, we can give the ACT regimen as per the area what we are treating. And I told you about the area also. So this is what we do in pregnant women. Okay, so please remember, in Vivax, radical cure, that is the use of primaquine, is after delivery. Very, very important. Now, falciparum can cause the complicated type of malaria or cerebral malaria. How do you manage that? The complicated or the severe form of malaria or the cerebral malaria. How do you manage it? This one can be managed with IV drug only because it's an emergency. So the drug of choice is IV artesunate. Now previously IV quinine was used, but the problem with quinine, I told you, the glucose will come down, arrhythmia can occur. So that's why the drug of choice is IV artesunate. Now once the patient becomes stable, then we shift the patient to oral ACT therapy or ACT regimen, we can give it. Sir, what about pregnant woman? She has cerebral malaria, same in all trimester. In all trimester, the recent guidelines tells that if there is cerebral malaria, the drug of choice is IV artesunate. Very, very important. Very, very important. Okay. Sir, you were telling combinations, correct? But are there any combinations I need to know of? Yes. There are certain combinations approved by WHO. WHO approved combinations, that is artemisinin combinations, are few you already know. Yes, come on guys. You already know artesunate plus sulfadoxine plus pyrimethamine. You already know this. Same thing, you have artesunate, along with that you add amodiaquine. This is another combination approved. And third, you already know, we use the same artesunate and with mefloquine. But here you should be careful. Now, mefloquine, when you think of that, it causes mental neuropsychiatric symptoms. So, which patient you should not use it? Cerebral malaria. Cerebral malaria patient, we should not use it. Very good. Now, I have told you the combination of altimether plus lumefantrine. So, you know that. And what are the other combinations? The other combination are dihydro artemisinin plus a drug called piperaquine. So these are the WHO approved combinations you can use for ACT regimens. ACT regimens, these are the WHO approved combinations. Sir, we understood all those things. But what if you are traveling to malaria endemic area? Some areas are malaria endemic, and when you're traveling there, you should take prophylaxis. Who has to take prophylaxis? We call it as malaria chemoprophylaxis. So when these people are visiting the endemic area of malaria, who are these people? The travelers or the migrant laborers. So who go there and work. Then the military personnel. So they require malaria chemoprophylaxis. So I was telling you malaria chemoprophylaxis that is required for travelers, migrant laborers and military personnel. Now, if the journey for the endemic area is less than 6 weeks, a short duration of journey, the preferred one will be doxycycline. Doxycycline. Now, when to start doxycycline? It can be started 1 to 2 days before journey. So 1 to 2 days before journey, it can be started. Now, let us consider this is the start of the journey and this is the end of the journey. So the question is, should we take during the travel? Yes. So doxycycline should be taken daily during the travel. Daily, every day. So the next question is, if I come back from the journey, patient will ask us, should I continue it again? Yes. After the journey is ended, again you have to continue doxy for daily for around 28 days, that is 4 weeks. And that is the meaning of what we mean by suppressive prophylaxis. Even in the last day, if the person has been bitten by the mosquito, doxycycline will suppress the manifestation of fever, chills and all. That's the meaning of suppressive prophylaxis. You can refer the video earlier what we have discussed that. If the journey is longer, more than 6 weeks, then the preferred is a longer acting drug. The name is called mefloquine. Now, mefloquine usually started 1 to 2 weeks before the journey. So this is the start of the journey and this is the end of the journey. Should we take it every day? Patient asks us, yes, not every day. The advantage of mefloquine is longer acting, so it is taken every weekly. So it's a weekly one tablet. So weekly one tablet. Then the patient will ask, after coming back, should we take it? Yes, mefloquine should be taken one tablet every week. How many weeks? 4 weeks. So again, up to 1 month. This is what we mean by suppressive prophylaxis. Right? So doxy and mefloquine. Remember, mefloquine should not be used in cerebral malaria. So the advantage is longer acting. Now moving on to the next important aspect. What is the next important aspect? What about in pregnancy? Should we give prophylaxis in pregnancy? Usually we don't have to give it. Only if the pregnant woman is in high endemic area of malaria. High endemic area, she has to begin prophylaxis, not in first trimester because the drugs we should avoid in first trimester. Particularly, WHO has recommended intermittent prophylaxis like a single dose. So, single dose of a combination that is sulfadoxine plus pyrimethamine. Pyrimethamine has to be given. When to give the single dose? One in second trimester and one more in third trimester. So don't give it in first trimester. So you can give it in second trimester and third trimester. Suppose you are given in second trimester and third trimester starts in 1 week. Will you give one more dose? No. At least you should give a gap of 1 month between two doses. Very much important. So that is about the prophylaxis of malaria. So basically, when you go through this video, anti-malaria drugs, what do you need to understand? You need to understand what do you mean by prophylaxis, what is causal and what is suppressive, what do you mean by radical cure, what we kill there and who will kill it, primaquine, tafenoquine, what is gameticidal effect, inhibiting the clinical transmission. Number 5, clinical cure, where we affect the erythrocytic stage. The drugs are high efficacious and fast acting. I told you the drugs chloroquine, artemisinin group, fantrins, and then atomocone. Then low efficacy, slower acting are antibacterial drugs, which you discussed already. The one which affect the folate synthesis, apart from the tetracycline clindamycin. Then chloroquine mechanism is to inhibit conversion of heme to hemazoin, and it has multiple uses. But when you think of chloroquine, think of two important adverse effects: eye ECG. Eye, the corneal deposit, bullseye maculopathy, and the pigmentation of skin and nails, ECG QT prolongation. Primaquine is a drug for radical cure, decrease relapse, and it killed all species gametes. Very much important. Contraindicated pregnancy and G6PD deficient. Similar to that, we have tafenoquine. Tafenoquine is longer acting, so for radical cure, 1 dose is enough. Then we have artemisinin group, new drugs, high efficacy, less adverse effect, and we don't want to use them for prophylaxis, always use them in combination. Then the treatment of malaria, northeast artemether lumefantrine, and in rest of India, artesunate, sulfadoxine, pyrimethamine. This is for falciparum. Vivax still today, chloroquine and primaquine for 14 days. Pregnancy, if it is chloroquine, if it is Vivax, chloroquine, radical cure after the delivery. Now, if it is falciparum, first trimester quinine plus clindamycin, second and third you can give ACT regimen. Cerebral malaria or complicated malaria, drug of choice is IV artesunate. Prophylaxis, less than 6 weeks doxycycline. One thing you have to remember, after the ending of journey, the patient has come from endemic area, you have to give the prophylaxis for another 28 days. Longer journey, you have to give mefloquine. Again, the advantage is longer acting. After coming from endemic area, you have to continue for another 4 weeks. So this is the summary of what you need to know in these anti-malaria topics. Thank you all.